Hi, my name is Dr. Jessica, and I am a chiropractor out of CHIRO for Moms. And I am here with Dr. Geisler, a pediatric dentist that owns Life Smiles and Release and Breathe. So, Dr. Geisler, would you please introduce yourself and explain how you got into dentistry and like pediatric dentistry specifically, and go from there?
Well, yeah, as she said, my name is Dr. Krista Geisler, and I'm actually a general dentist, or we like to call ourselves primary care dentists. So I can treat people of all ages. I do like shift and I treat a lot of very young people and a lot of young children, but I do see, even up to senior citizens. So I became a dentist, was always into science, but I always liked interacting with people. So needed to find a career where you're like with people, but you're like scientific. And the nice thing about our job is a lot of times there's an immediate reward. Like I don't have to wait a year to do a research project to come up with a result. Like there's some instant gratification or very short gratification to see how you're affecting people's lives. So,
Oh, that's amazing. So, Dr. Geisler, you focus a lot on like looking at the airway and looking at how the tongue posture and how stretchy the tongue tissue and everything is. So, how do you determine whether or not an individual needs more of that release of that tongue tie or more stretches to encourage that general flow a
mhm.
bit better?
Well, if we can break it up and think about, should we talk about infants first? And
Sure.
then maybe talk about children and then adults, maybe as three groups. For
Perfect.
infants, I always ask that they see a feeding specialist, a lactation consultant or an SLP OT who knows about infant feeding and suck, swallow, breathe pattern. And so I'm doing an anatomic look and seeing if it's stretchy enough to get to the roof of the mouth and looking for signs in their mouth, like a flattened lower ridge or a narrow palate or a thick amount of milk on the backside of their tongue that might be telling me they're not elevating. And then you have to look at the list of symptoms of if the mom is breastfeeding is having and what the baby's symptoms are. And you have to kind of listen to what the feeding specialist says, listen to what the body worker says as well, because a lot of times they'll say, there's this tension in their neck, or we keep treating and the baby's not getting better. So you have to marry all those things together. So it's not just anatomic. That being said, I saw a baby just yesterday that was tied to the tip, and so there's no stretching of that. I do still work with the lactation person and the body person to get that baby a best result, but that one's pretty locked in stone, or pretty sure that that's a tongue tie. So
Absolutely. And then when it comes to like the older ages, the children, are you asking obviously different questions? And then same thing with
mhm.
adults later as well?
Right. So when they're kids, like for instance, in my general practice, when I have kids try to suction their tongue up to the roof of the mouth, some of them have never done it before. So if we measure that, like with millimeters, we measure between the edges of the teeth, they might not have a great number. But that being said, they haven't like exercised or worked it and been conscious of trying to do that. So again, unless it's very tight, you have to go through some therapy. With a lay term is myofunctional therapy, or oral facial myofunctional therapy is the kind of longer term. And exercise and do as much as they can, and then we measure and we look at, can the back of their tongue reach their palate, and there's a certain ratio. We're looking how wide can they open their mouth versus how high can they lift or suction their tongue up to the roof of the mouth, and we look at a ratio, and then we can kind of decide, you know with a functional specialist, do they need a release or not.
Okay. That's amazing. And then specifically with infants, is it a grading that we like assess? So like if it's grade 1, grade 2, grade 3, grade 4, or is it just how the tongue is moving and how it's functionally working?
I think it's more the second. There are different ways to rate tongue ties, like 1 through 4, and then the other one is 4 through 1. It's the opposite. And some people say, how severe is it? That's what the parents ask me all the time. How severe is it? And I've seen babies who are tied to the tip who are breastfeeding just great and don't have a lot of symptoms. And then I see babies who have a tie that's harder to find, and the mom isn't breastfeeding, or their failure to thrive, or, they're so gassy, you can't lay them down, all these symptoms. So how severe it is really like, how is it affecting the baby and the family versus anatomic? Because um, we all have different capabilities of like compensating and our range of ability to adapt to things is different. So
That's a good. And what is like the optimal age to do the assessment? So how long do you want mom to try breastfeeding before coming in for that initial visit, or is there a perfect timeline?
there's the perfect timeline is when the baby and the family have gone through the therapy that they need ahead of time. Their body is ready, and the feeding specialists and the body workers say they're ready, and the family is ready to go. So sometimes that's at day 7. So, and sometimes it takes 3 months for the family to go through some process, work some things out, get the body relaxed out of that fight or flight. And then they tell them, right, it's right. That being said, the earlier the better, as long as people are prepared, because you don't want to do something too early because you can, you know, make it tumble down the wrong path. You want things to be going better, not worse. So
Is that the same with like premature babies versus babies that go to term as well? Like we
that's
want
a
to
good
do all of
question.
the body work and
I think it's the
Mhm.
same. When they're medically compromised and they were preterm, then we have to work with their physician to make sure it's safe to do it. But I've seen babies who were born at 32 weeks and now they're, age adjusted like 38 weeks, but they've done a lot of the work and they really are struggling. So it's okay to release them when they're really little, as long as we're not, again, going to make feeding worse. We want to make sure that they're gaining and they're healthy throughout the process.
That makes sense. And
Mhm.
when a baby goes through that revision, do you provide stretches for the mom to do at home?
Mhm. Yep, and we demo them and have them demo back to us, whatever caregivers are with us. So they get comfortable going in their mouth. One of the best predictors of like how well it's gonna go is if the parents have some self-confidence that they're able to get into the mouth and do the stretches. If they don't feel like they can do it, then it's harder for them to actually do it because their baby is probably gonna be uncomfortable in the beginning. And it's really hard to do that for your baby, if you don't have the confidence to do it, so.
Absolutely. And just providing that, getting them to initiate that confidence is key for them, especially when it comes to recovery as well for that little
Mhm.
infant. Just getting that confidence to start breastfeeding
Mhm.
again and just work right through it, right?
And I find that the parents who have been practicing like the oral stretching before they even meet me do even better. They're just the baby's used to fingers in their mouth and they're not shocked by it. The parents know how to access the tongue. So those parents do even better if they've had some experience before, like their first visit here and we're showing them that's the first time they've been in their baby's mouth. So
Absolutely. And that can come from like craniosacral from lactation consultants that are adverse in tongue ties, just learning how to do those stretches from other modalities, getting the body work done before coming in to get the
exactly.
piece done.
Yeah, yeah. A lot of the people who refer to us are already doing that with their families and have set their families on a really good path towards being ready to go.
Yeah. Oh, that's amazing. And then when it comes to reattachment, or have you ever seen like the reattachment type where baby's tissue doesn't heal as well and then it gets a little bit tighter with a little bit of scar tissue, but not necessarily like full reattachment, just a little bit less.
Than ideal.
Yeah.
Yeah, that happens. Sometimes they're perfect, weeks or months after, and sometimes they're attached like super strong, but a lot more than that. Sometimes they're just like not as open as you want them to be. So you try to work with things that aren't ideal all the time. The body is trying to heal it. So reattachment isn't a bad thing. The body's doing what it's supposed to do in a healthy way. We're just trying to trick Mother Nature. So we've been starting to use something that's kind of newer out there called serapeptase to sprinkle on the wound. If we're getting the feeling like, and it's more of a feeling than a look, and we're like, okay, at day 5, 6, or 7, when they come in for a follow-up, we're like, oh, that's tight. Or if we're seeing them at 2 weeks or 4 weeks, and we're like, oh, that's tighter than we want to do, we teach them how to use serapeptase to kind of try to soften that scar tissue.
Okay, amazing. And that is just a topical that mom puts on?
It's a powder, it comes in a capsule, so it's like a whole food supplement, or it's a supplement that people take, and it's used to kind of break up that scar tissue. So it's safe for infants to use.
Yeah. Oh, that's incredible. I never heard about that before.
Yeah, it's kind of a newer way to treat babies, so.
I love it. Any like long-term consequences, like say parents do not want to do the revision, but then later on in life, they decide to do the revision? Like, what does that kind of timeline look like for
Mhm.
what can happen to babe or what can babe experience with symptoms?
Right. And sometimes the parents are struggling with breastfeeding and they give up breastfeeding, which is an okay choice. But sometimes if you're choosing to breastfeed and you can't, then there's some downfall on that connection with the mom and the baby. And actually breastfeeding is really good for jaw development. So if the breastfeeding was desired but not able to happen, that can be a long-term consequence. The jaw doesn't grow quite as well. But beyond that, a lot of these kids will have difficulties even with purees and they're just not eating well. And the parents will say they're picky and meal times take forever, they're messy. They'll only eat like 3 foods. It's because not because it's not a personality thing or a choice. They can only choose so many foods and swallow them without having a problem aspirating. So the kids are being smart and protecting their airways. And so eating can be difficult. Speech, that's one of our, besides chiropractors, our biggest referral is speech therapists because they're trying to make their sounds, and in speech therapy for sure years before sometimes they realize that there's a tongue tie. And so that's something that people have to realize, like how frustrating that is for kids to not be able to communicate. Or I went through speech as a kid. It's kind of like, oh, I got pulled out of school to go to speech or out of class. And so like there's some self-confidence issue when people can't understand you. And when you have a tongue tie, it increases your risk of having both pediatric sleep apnea and adult sleep apnea. And that is a really major medical problem. Also increases the risk of or the chance of having a really bad bite. And there's a variety of bad bites, but for sure, having a tongue tie, it's going to show up in the jaw growth and development.
Okay. What does sleep apnea in infants look like?
Sleep apnea in infants, that's a good question. Sometimes parents are aware of it and the baby kind of gasps awake. So that
Okay.
would be a common like a startle awake and they're just not staying asleep, like having long stretches of sleep. That being said, there's more than one reason why
Mhm.
babies have shorter stretches of sleep. But what is happening like through your body physiologically is there's chronic intermittent hypoxia, so low oxygen. And if you have that just a little bit, chronically, it affects how our brain develops. So that's not something parents are going to pick up on, but that's
Right.
going into maybe more the risks of the pediatric sleep apnea. So not
Right.
being able to sleep on the back, not being able to be laid down, those might be some signs that you're struggling with that.
Okay. Would mouth open be a contributor as well? Like if babies are sleeping with their mouth open?
Yeah, I would say, I guess I haven't met a baby who had, or a young person who had sleep apnea who was nasal breathing.
Okay.
So the tongue tie, almost all those tongue tie babies are mouth breathing, but not all of them. And not
Mhm.
everybody who mouth breathes has a tongue tie, but it's really a strong association with the tongue tie, mouth breathing, and then sleep apnea.
Okay. Okay. And then when it comes to the tongue, it's just really important to encourage that tongue to be on the roof of the mouth to help form the palate, to create that
Mhm.
soft, open, more like not like a super high rainbow, but like a nice rainbow arch so
Yes.
that everything else around us develops as we get older, correct?
Exactly.
Okay.
And some people don't know, but all the stuff that hangs in the back of your throat, like your tonsils and the thing that dangles down called the uvula, it's hanging off the back of your palate. And so if it's really narrow, all those tissues are narrow, and the eustachian tubes, or the tubes where we drain our ears, they come in right behind that. So if everything's too narrow because the tongue hasn't been up there, more chances of having ear infections, snoring, dry mouth, all sorts of some area problems with the back of the throat being small, like more strep throat, more infections, asthma, allergies. So
Okay. And same with when it comes to like milk tongue, everything like that. If baby has a lot of milk tongue, they're not like scraping their tongue on the roof of the mouth and everything because the tongue can't get stretchy enough to clear it.
right, right.
Okay.
And most of the time that's a tongue tie, but sometimes babies
Mm,
have some motor neural
sure.
issues why they're not elevating their tongue. So I don't think the milk on the tongue in itself is a problem. It's just a
Mhm.
sign of how they're functioning or not functioning as well as we'd like them to.
Right. Okay. And then with when a baby goes through the revision, is there a timeline when you want to see baby back for like a reevaluation, or do you want them to see a couple body workers before they come back and see you, or kind of mixed together so that everybody's working as a team?
Good question. Usually the body worker will want to see them for sure in the first 5 days, sometimes the next day, sometimes within a couple days. And so they're checking their body and lactation usually within that first week. And then I like to see them day 5, 6, or 7. So there's definitely some overlap. And then sometimes we see them at 2 weeks or 3 weeks or 4 weeks. And then the body worker would be the person chiropractor saying, oh, we need, 2 sessions a week, I think. And they'll be the one to tell the parents, okay, I think we're good to go, to stretch it out a little bit longer. And the lactation consultant also, how much support they need is, will determine how many appointments they need afterwards. And every family is a little bit different. So we can't say, oh, going to need 2 sessions after this. I don't know that because I'm not the chiropractor and I'm not the lactation support person. So you have to listen to the, people who are the professionals and the specialists and do what they what they recommend.
Absolutely. And I know at our clinic, we typically like to see the babe day before and then the revision and then day after as well, just to help
So,
support that tissue. And then however many times after that, depending on the babe. If
and I
babe
think
is, yeah, if babe is feeling great, great, awesome. We provide the stretches for at home for parents to do for the full body, just to help lengthen out that tissue as well, which is really lovely.
and what we're not talking about is like the emotional support. You guys spend more time and you know these families really well. So
Yeah.
you're like part of their village, like surrounding them and
Yeah.
giving them support through this really tricky time. So like there's no price that you can put on like how much support you guys are giving them.
Mhm. Yeah, and just having a whole cohesive team is just really nice to like have all of the brains working together to help this family out.
Right, right. We all
Yeah,
have their best interest in mind. So
absolutely. Is there a difference between anterior posterior tongue tie, or can you explain those differences
mhm.
between the two?
That's a good question. A lot of people ask me that. And then we're talking about a midline tissue under the tongue. So posterior in dentistry means towards the back of your mouth. But it's kind of a tricky term because people think we're talking the back of the throat, like way back down under the tongue, but everything's under the tongue. And it's just talking about where it inserts to the blade of the tongue, the free tongue. The anterior ones are tied like to the tip or close to the tip, and the posteriors are back here. All of them are keeping the middle and the back portion from being able to elevate. The ones towards the front are also keeping the tongue from being able to go side to side or to elevate. Some of them are keeping them from protruding. One of the things I hear often is somebody in their healthcare team said, well, they can stick it past their gums. But I would challenge any adult to like try to eat your next meal by just sticking your tongue past your gums and see if that makes it easy to swallow. We're always talking about elevation. Elevation is key. I mean, everything else is key too, but elevation. So the babies have to lift their tongue up and bring the milk back, not just stick their tongue out.
Okay, that's good to know.
Mhm.
And then is there correlations with, so let's chat about a little bit of lip ties as well.
Okay.
So how do the lip ties affect like the function of the mouth as well?
Mhm.
And
That's
like teeth coming in and that type of thing.
Well, for breastfeeding, we want, or bottle feeding, we want the lip to make a seal. So if the lip is uncomfortable, the baby might like pop off latch a lot or not make a seal. So they'll swallow air and just not get a deep latch. If it's really tight right here, you probably want to stay shallow. And then your tongue, even if it's not tethered, can't do its proper job because you need to have a good deep latch. As far as dentition, it's normal to have a gap between baby teeth. So when they come in, if you see a gap, that's normal. If the gap's super big, like 3 millimeters, then we might think there's a frenum involved. But if there isn't a gap and those baby teeth are touching, then we know there's some crowding. And it may kind of make sense to us to tell people that, oh, your child will have a higher risk of having dental decay on their baby front teeth if we don't release a lip tie. But more recent research that's coming out hasn't shown that a lip tie will increase the risk of having dental decay. So it's not something that we tell parents anymore.
Okay. Is there a way that parents can just like look at the lip tie to see like do babies bottle feed and breastfeeding typically have like a blister up front to have like more of an indication, or like is there like we can stretch it all the way up to
Yeah,
see if there's like a really big
right.
like tension or anything like that. But is there a way
Yeah.
that parents can just like look at that at home on their
I
little
would
infant?
I think the blister maybe could give you a hint that you should look deeper, but that in itself
Okay.
won't tell you. If you're lifting the lip and it can't get like up to the nose, then that's a concern. Or, functionally, if they're trying to flange the lip,
Mhm.
so it's either neutral or flanged, and it won't do that, they keep tucking it back, that's a sign. But
Okay.
over 90% of babies have a frenum that attaches right to the ridge. So
Yeah.
that's not the problem. Most parents are like, oh, it's a tie because of where it's located. That's normal. It's just how stretchy it is. So if you're lifting the lip up and then the gums right where it inserts, kind of right at the ridge, turn bright white, that is a lot of tension in there.
Okay. It's kind of
Mhm.
like poking your finger and it turns white because there's tension putting on your
Exactly.
finger, right? Okay.
Exactly. It should be like able to lift up. Baby shouldn't be like super uncomfortable when you lift it up, not blanching, and be able to maintain a seal in a deep latch.
Okay. And then is that kind of the same thing with like buccal ties or buccal, buckle? Am I saying that correctly?
Well, speech people call it buccal and dental people call it buckle. So it
Okay.
depends.
Okay.
Tomato, tomato, like what you want to call them.
Right.
What was your question? Like, what's the question about both?
Is there like the correlation between like getting too much air in and that suction seal with buccal ties as well, or are those just kind of anatomical?
Well, we think so, and we're doing releases for them, but there isn't research to prove that yet. So I'm usually listening to the functional person, the feeding specialist, to telling me if those are interacting or interfering with their feeding. Also, a lot of times babies have a head turn or a tilt, and I go in their mouth and so commonly their frenums are very asymmetric and like one's super tight and one's normal. So we want to balance that out so they have some symmetry with how they can function. But new research has come out, and it wasn't really research, it was more of a survey of like how many dentists like myself are looking for them, how many release them, and trying to come up with a grading scale. So it's really like a frontier that's still to be explored.
Okay. And that's what
Mhm.
I'm finding in my clinic too. I stretch the tissues just to kind of see what's going on in there. And most times, if they have that right-sided head preference, they have that full right-sided tension going all
Yeah.
along the jaw.
Right, right. And I can only release like the frenum tension. I'm not addressing like the whole cheek and the jaw being tight.
Right.
But I'm glad that you're noticing that too. It's not
Oh,
just me.
big time. And so I'm always telling parents like head preference, get in their mouth. Always just get in their mouth and just stretch out everything. So
That's good advice.
absolutely. Um, well, I think that's all the questions that I have. And so thank you, Dr. Geisler, for being here today with us. And I hope you have a wonderful day.
Thank you. You too, Jess.
Yeah.
Bye.